Hi everyone, I'm Dr. Sanan Sari. Welcome back to my channel. Today we're talking about a very important topic for MRCOG Part 2 and Part 3 students, shoulder dystocia. So what exactly is shoulder dystocia? Basically, you're finding it difficult to deliver the fetal shoulder after the delivery of fetal head. Now, if this time from the delivery of fetal head to the fetal body takes more than 60 seconds, then it is called a shoulder dystocia. It is usually because of the impaction of the shoulder behind the pubic symphysis and it requires additional maneuvers. Incidence is 0.6 to 1.4%. The majority of the cases they occur without any risk factors. So it's difficult to predict a case of shoulder dystocia and you should be prepared for it. The recurrence risk is 10 times more and it is often associated with fetal macrosomia. Now, the risk factors include maternal, fetal, and intrapartum risk factors. So, on the maternal side, if there is risk of diabetes, that increases the risk to 2 to 4 times more. If she's obese, if there is previous history of shoulder dystocia, or if there is excessive weight gain in pregnancy. Now, intrapartum risk factors are prolonged second stage of labor, if there is use of instrumented delivery, if you have induced or you have augmented the labor. Fetal risk factor is macrosomia, baby weight more than 4.5 kg, or if it's a post-dated pregnancy. Now, the question is, can you really predict a shoulder dystocia? It cannot be predicted because many cases occur in normal weight babies, and risk factors have poor predictive value. So, can we prevent shoulder dystocia? See, if it is a macrosomic baby, then we can plan for elective cesarean. For diabetics, the cutoff is more than 4.5 kg. For non diabetic, it is more than 5 kg baby weight. And routine inductions just to prevent shoulder dystocia is not recommended. So, how do we recognize shoulder dystocia? There is turtleneck sign, failure of restitution, and difficulty in delivering the shoulders. So, the immediate response once you have diagnosed shoulder dystocia is always call for help. Now, this is a very commonly asked question. The first thing you do after diagnosing shoulder dystocia is call for help immediately. Stop traction. Don't ask the patient to push or don't apply any fundal pressure. Lie the patient flat and start the maneuvers. So, this is the shoulder dystocia drill. As soon as we recognize shoulder dystocia, always call for help. First, perform McRoberts maneuver. I'll be explaining in detail about each of these maneuvers in further slides. McRoberts maneuver along with suprapubic pressure. If unsuccessful, you move on to internal maneuvers, which is Rubens or wood screw. Then the next step is posterior arm delivery. And if that also fails, you perform all fours maneuver. Now, the first important maneuver is McRoberts. Here we hyperflex the maternal thighs. We are increasing the pelvic outlet diameter by straightening the sacrum. The success rate is 90%. Along with this maneuver, we apply suprapubic pressure just above the pubic symphysis. Now, this usually push the fetal shoulder into the oblique diameter, and we never apply fundal pressure as I told before. The next maneuver is the internal maneuvers we do, which is Rubens maneuver. In Rubens maneuver, we are applying pressure on the posterior aspect of anterior shoulder. Now, this usually adducts the shoulder and reduces the shoulder diameter. If that is also not successful, then we move on to wood screw. Now, as the name suggests, it's a rotational maneuver. Here, the pressure is applied to the posterior shoulder. In Rubens, we are applying on the anterior shoulder. In wood screw, the pressure is applied to the posterior shoulder. The next step is delivery of the posterior arm. You insert your hand posteriorly, flex the elbow against the chest, and deliver the posterior arm. Now, once the posterior arm is delivered, this reduces the shoulder diameter significantly. Now, the next maneuver is Gaskins, where the mother is lying on all four positions instead of a supine position. Now, if everything fails, the last resort maneuvers are clidotomy, Zavanelli's, and symphysiotomy. Now, Zavanelli maneuver is a very important MCQ. When do we perform it? If the fetal shoulder is above the pelvic brim. So basically, we are pushing the fetal head back into the pelvis and we are performing a cesarean section. Now, the maternal complications include tears, PPH, uterine rupture, that is rare. Fetal complication is brachial plexus injury. This is also a very commonly asked question. This is the most common fetal complication, but it is transient. Less than 10% of the brachial plexus injury leads to permanent neurological damage. It commonly involves C5, C6. Other complications include fracture of clavicle, humerus, there is hypoxia, or in rare instances, there is neonatal death. Let's do some MCQs. First maneuver in case of shoulder dystocia. A is McRoberts, B is Zavnelli, C symphysiotomy, D is sclerotomy. So the answer is McRoberts maneuver. Next question is, which is contraindicated in case of shoulder dystocia? Suprapubic pressure, fundal pressure, Rubin's maneuver, or delivery of posterior arm? The answer is fundal pressure. Now, in case of shoulder dystocia, what is the initial management as soon as you diagnose? These are all the options. McRoberts, suprapubic, Rubens, foot screw, or posterior arm. So your answer is McRoberts. If it would have been call for help, you would have chosen for call for help followed by McRoberts maneuver. So this was all about shoulder dystocia drill. If you have any questions, let me know in the comments. Thank you.